In the current clinical landscape, cardiac transplantation remains the definitive gold standard for end-stage heart failure, that is stage D. Yet, the field is undergoing a paradigm shift driven by improved organ preservation, refined allocation systems, and the burgeoning reality of xenotransplantation. Hemodynamic triggers for transplant listing. Listing is typically indicated for patients with a VO2 peak less than or equal to 14 ml per kg per minute or less than or equal to 12 if on beta blockers, or those dependent on continuous inotropic support or temporary mechanical circulatory supports. Temporary mechanical circulatory support versus durable mechanical circulatory support pivot. Recent allocation changes now prioritize patients on temporary support like Impella 5.5 or ECMO over those with durable LVADs, that is left ventricular assist devices like HeartMate 3. This has led to a significant shift in bridge to transplant strategies, with clinicians often opting for temporary percutaneous support to achieve higher listing urgency. The 4-hour window for cold ischemic time is being challenged by two major technologies. Normothermic regional perfusion. This has drastically expanded the donor pool by allowing for donation after circulatory death. By re-establishing regional perfusion in the donor, the heart can be assessed for viability before procurement. Controlled cold storage at 10 degrees centigrade. New data suggests that maintaining donor hearts at a constant 10 degrees centigrade using specialized perfusion devices rather than the traditional ice slush at 0 to 4 degrees centigrade significantly reduces primary graft dysfunction and extends safe transport times to over 8 to 10 hours. Management is moving towards renal sparing and cardiac allograft vasculopathy preventive regimens. Sirolimus conversion. The standard of care is shifting towards early conversion from calcineurin inhibitors like tacrolimus to mTOR, that is mammalian target of rapamycin inhibitors like sirolimus at the 12-month post-transplant mark. This has shown superior outcomes in mitigating cardiac allograft vasculopathy and preserving glomerular filtration rates. Early initiation of mTOR inhibitors can increase the chance of early rejection and affect wound healing. That is why the cutoff of 12 months when wound healing is complete. Pegrisiprumant, that is a novel CD28 mediated T-cell co-stimulation blocker which has received FDA orphan drug designation yesterday. It offers a potential path towards maintenance therapy that avoids the nephrotoxicity associated with long-term use of calcineurin inhibitors. Following two landmark human pig heart transplants, the ISHLT, that is International Society of Heart and Lung Transplant, 2026 consensus statement on clinical cardiac xenotransplantation now serves as a living blueprint. Current status. While the first cases reached 40 to 60 days of survival, they provided critical data on porcine cytomegalovirus screening and antibody-mediated rejection patterns specific to xenografts. Genetic engineering focus has shifted to 10 gene edits, knocking out 3 carbohydrate antigens and 1 growth hormone receptor, while adding 6 human regulatory genes to overcome hyperacute rejection. Success rate in high volume centers in this region are around surgical success 95%, 1-year survival 90%, 5-year survival 70 to 75%. The primary challenge remains the scarcity of donor organs, leading to an increased reliance on destination therapy with durable left ventricular assist devices for those who do not meet the increasingly stringent psychological or physiological requirements for a transplant.